Oh, there we go. Okay. Um, all right. Sarah and I are going to present just on the differences between quantitative and qualitative data. I know we're all on the first chapter, the assessment portion for your strategic prevention planning process. I think it's reassuring to hear that this is really kind of the lengthiest portion. Um, because it's gathering tons of information and then sorting through it and refining what our priorities are, which is not an easy task necessarily. So, this is something that Charlie Seltzer put together and presented, and not all the slides are here. It is definitely in the shared drive. So, in terms of data, we've already talked a little bit about the fact that it allows us to look at the big picture. Sometimes, when we're considering health in Humboldt County, it can feel overwhelming. Like, what are we supposed to do? What are the 30 of us in our division? How are we going to impact the health for the entire population of Humboldt, 134,000 people? So, data allows us to address the fact that, yep, we have tons of problems and maybe not enough resources to go around, but we want to do something. So, what should we focus our efforts on? And where do we start? Sorry. This is taken specifically from AOD, so it's talking about the substance abuse prevention field, but really it applies to any field. We can look at data in order to get a firm grasp on where the problems are, where they're found, and specifically who are at risk, right? We also can take a look at the underlying causes that's revealed by the data that we're looking at, and then design our programs based on the most efficient way to address those problems. So, what is data? I mean, data is everywhere now. I think it's really important to think about the fact that just years ago, access to big data didn't exist. And that probably is reflected in the approach to public health, which used to be more individually based. And now we're looking at population health because we can. And that capability didn't exist just a very short time ago. So we're so used to dealing with data right now, we don't even think about it. One example that was brought up is like, and I won't make you raise your hand because I hate when people ask me to raise my hand. But if you think about the fact, well, have you ever like gone somewhere strange and tried to find a restaurant and turned to a Yelp review, right? So the quantitative piece of that resource would be, well, how many stars does that restaurant have? How many reviewers have given it a good review? And so that's just one tiny example of how frequently we are accessing big data. I thought this slide was useful in terms of looking at risk and protective factors. Allison did a great job of addressing it. And some of the factors that we also look at are the different contributing areas. So we look at things from an individual level, a family level, perhaps we're looking at the school environment, and also the community at large. I'm not sure if you put this in your slideshow, Sarah, but this just talks briefly about the difference between quantitative and qualitative data. So really, basically, anything that's expressed numerically is quantitative data. It might also talk about how often a behavior or an event occurs and to what degree it exists. And I'm going to let Sarah address qualitative data later. So here's some examples. We've seen some of these before. 25% of the students at Eureka High School had their first drink before they were 15 years old. I made that up. 95% of injection drug users in our community have hepatitis C. 15% of hospital admissions are associated with excessive alcohol consumption. Do you all know the prevalence of Hep C in our population? 5%, which is huge. Like, we win the prize statewide, practically, for newly identified cases of Hep C.
But then 95% of injection users have Hep C, so it goes from 5 in the general population to
So this
95?
is an example that is taken from Charlie Seltzer's presentation. This
Oh, it's
doesn't
not
specifically
okay.
apply to Humboldt
Okay,
County.
sorry, I was like, man, I would've
But the
been-
one that I just told you is real. The one that I just told you is
It
real.
probably is like 80% of injection drug users would be the most national estimates. 60.
So this is just telling you what some sources of quantitative data are. Maybe you don't have this in your mind, and it is in the workbook. Things like surveys, counting, pre and post tests, or existing statistics. And I do want to tell you that in the shared drive, we have put together a resource page, and we'll stick it in the strategic prevention folder as well, of data sources for you. I know you've all been really busy gathering these on your own, but we want to make sure you have access to, kind of some of the standard sites. Is anybody willing to share an example of maybe a survey that you do, counting that you have done? Here's an example of each of these things in your programs.
The QPR pre and post survey.
So that's your suicide prevention training pre and post survey, and that's designed to
To just, in a very basic way, measure what people knew about suicide, how comfortable they were with asking somebody about suicide, and then we give them that before the training, and then we give them the post survey after the training.
Okay, so their comfort with asking people about suicide and their perception of their knowledge.
Yeah.
Okay. Any other examples that you all can think of?
Within the NEOP program, when we do direct education, we have all the participants fill out a data sheet, which is basic demographic data. And we know what other government programs they're enrolled in and their age.
Okay, so you take demographics from your clients. Cool.
In the Safe Routes to School program, we survey parents of our schools every year, and we get qualitative and quantitative data, so we get to
Didn't you see that's like 14,000 surveys a year for the Safe Routes to Schools, quantitative and qualitative, to the parents? Are they still sitting at your desk? So if y'all want to look at them. So crazy amount of juicy data that you have on your hands. Does someone analyze that for you and aggregate it, or you do it?
Basically, we just got that yesterday.
Mhm.
The National Center for Safe Routes to School has been processing them and making these like really fancy reports that can be individual to the school or the district. They're going to stop doing that November 15th. So we will have to come up with a plan of how we're going to proceed.
Oh, my stars. Okay. I'd love to be in on those meetings. So these are just some examples of surveys that'll be listed on the resource sheet that we've compiled for everybody. We already talked about the California Healthy Kids Survey, Monitoring the Future Survey, National Survey on Drug Use, etc., etc. I think it's a really good idea if you're not familiar with these data sources and you've never manipulated them before on your own, to talk to the epidemiologist, Ron, and say, Ron, please give me your take on this, because he knows the ins and outs of working with each of these and can maybe let you know not going to be worth your while, or you can get juicy tidbits over here, or maybe consider this alternate source of data. So let's talk some about examples of things that you're counting in your programs. Here we have things like the number of DUIs per month, the number of youth admitted to treatment. Of course, this is AOD specific, but how about outside AOD? What are some things that we count and keep tabs on?
Number of media exposures.
The number of media exposures for your NEOP advertising, and how do you do that? Are you getting that from the television stations, and what kinds of information do they give you, Laura?
They give us, we gave them specific DVDs and they tell us how many times they played it.
Okay.
And we know what the general population is that's watching,
Mhm.
and then we times it by a particular factor that represents the SNAP-Ed eligible population.
Okay, that's super interesting in terms of how many SNAP-Ed clients might be looking at that information on TV. I think online ads are such a powerful tool that we're just starting to utilize and hopefully start to utilize way more. As an example, the prep advertising, was it on Scruff, Allison? So you can get information like how many times does someone actually click this ad, and then once they actually do a referral to your service, get a sense of, okay, how many clients are we getting in through the door every week based on the ad that we're running. Okay, thanks for that example, Laura. So you have collected all this data, put it in a pretty folder in your strategic prevention file, and now you're wondering, what the hell am I supposed to do with this? So we're looking at problems, we're looking for trends, and next steps are going to be able to help you figure out what problems are most prevalent, which are meriting your attention, and are you making a difference by looking at, data over time. So we will be taking a look at goals based on the data that we collect. One term that I heard in our training that I thought was really interesting, because data-driven programs seem to make people have questions. And somebody said, well, what about the term data influenced? So I think that's a good way to look at data. It's not like you're a slave to data or the numbers, but it certainly should be informing your program goals, right? So once you have a problem statement supported by data, and we'll move on to that later, then you can start looking at setting your goals. So an example would be delay the age of first use of alcohol. I'm going to skip this. And I'm going to skip this. And I'm going to skip that too. And I'm going to skip this. I think this is a great slide because it talks about the logical sequence of our strategic prevention planning and how we get from one place to the next. So we start with the data, we analyze it, we prioritize it, and then we start moving on to identifying problems that exist and setting goals. From there, we've got objectives for each goal, and then we move on to strategizing and ensuring that we are moving towards our outcomes. So those are next steps in the strategic prevention planning process, but I think it's important to kind of get them in our brains now. All these slides are in the shared drive, okay? Do you have questions before I turn it over to Sarah? Did everybody feel pretty solid with what quantitative data was? Right on. Okay. Sarah, over to you. It's recording. It's okay. So you just have to advance your slides right there.
Hi. So I'm going to be talking about qualitative research, and the reason can you see my? Yeah. The reason I'm the one who's going to be talking about this is because when I did my grad school, this is the kind of research that I did. I specialized in, and I was really fortunate to have great mentors in this. That being said, I worked on it solidly for a year, like 70 hours a week, and I still consider myself a beginner. And so it's important to remember as we're leaping into doing all this stuff, no matter how much experience we have. I know a lot of you have experience with it through work, probably more hours doing it than I do. That's still not to have too high of expectations of ourselves, right? Like, be reasonable and be gentle. So, by the way, Clueless, the movie Clueless, is the theme of my presentation today. So, qualitative data is different than quantitative data, right? So we love concrete and simple ideas. We love to measure outcomes, and we love it when we can just generalize things to the larger community and move on, right? Unfortunately, we can't always do that. So Health attitudes and behaviors and changing them are complex and nuanced, and outcomes can show what exists, but not how it exists or why it exists, right? And so Cher here is wondering, like, why didn't her date go well? Did her hair get flat? Did she walk into bad lighting? She doesn't have the info. If she did an informative interview with the guy she was on a date with, she would discover, no, it's because he's gay, right? So she had to go to the person who has the information. And I like this quote. So qualitative research involves finding out what people think and how they feel, or what they say they think and how they say they feel. It involves feelings and impressions rather than numbers. And these are some examples that I pulled from one of our presentations, just some quotes. So this is qualitative data. So one, I'm not concerned about underage drinking. All kids do it. I did it when I was young and I'm okay, right? And then the top quote, I think this is actually from Mendo maybe, but it kind of applies to us too. There used to be thriving timber and fishing industries in our county. Now the trees are cut down and the fisheries are fished out. Thousands of people lost their jobs. That's when some people started growing pot and others making and selling meth. People had to earn a living somehow, right? And so this is something that quantitative data can't capture, that feeling, that emotion, that view of the community member. In gathering qualitative data, in order for it to be good data, we have to remember who we are within that process. What is our agenda? What are our goals? What social class do I belong to? Am I male or female? Am I a member of a marginalized group? How does that affect the way that I am interacting with the people that I'm gathering data from? And it's really letting go of that positive mindset. So like the idea is that human reason is supreme, that you can find a single objective truth, and that the world is rational, right? Because it's not. It's nuanced, it's complex. Many different things can exist at many different times, and the subjective experiences of our clients, our patients, and our community members really do matter. That doesn't mean that qualitative research is all about feeling, right? There are ways to make it valid, and we're really fortunate because in the last 40 years, a lot of work has gone on in sociology and other fields to really bring it in and find out, like, how are we going to make it valid, and how are we going to ensure that the data that we're getting is reliable? And the Robert Wood Johnson Foundation actually put together, I'll email this out, a great website that has the basics of gathering qualitative data, the different kinds of methods, different things to consider. It really lays it out beautifully, and I would be happy to look at it with any of you if you ever want to do qualitative research for your programs. And that's just Cher being a snob about her data. She's not a prude, she's just highly selective. And so the qualitative research process, it looks simple, it can get really complex, but it's really three things. So the theory that you're using, and we're not going to get into that today, but whatever theory you come from, it informs how you're going to do your research and why you do it that way, and it can really guide you through. I have a favorite theory that I can share with you. It really is a simple thing to follow to gather information, either from groups or individuals, but we can get into that at a later time. The method is just keeping really good records, which I feel like we're all good at anyway because we have to gather so much stuff for our programs. And then the analysis just goes along with whatever theory that we use, right? And unlike quantitative research, qualitative research method, gathering information and analyzing the data sometimes have to happen all at once. And I'll talk more about that. So the high quality, just keep good records, code all responses the same way. I'll talk about coding later. Using a theory, having multiple people look at it, saying, this person said this, what do you think this means? And then discussing that. Are we both getting the same meaning from what this person said? And then opening up and being upfront about our bias and our conflicts and about who the participants are and who we are in relation to them, right? Were they being honest? Do I have the power to take something away from them? Is that coloring what they said to me? And Carl Atkin, one of my professors and somebody who really stressed me out, always said, if it was easy, you're probably not doing it right. And so that was just his reminder to us to constantly slow down and look at it again and ask someone else to look at it and ask for help when we need it. And the first time he said that, I thought what Cher thought, like, you are a snob and a half. Who are you to tell me I'm not doing it right? So data collection techniques, there are more than this, but I just listed surveys. So not the counting within the surveys, but any of the textual, the narrative information, interviews, structured or unstructured. So you can have a list of, I'm going to ask you these 5 questions, and you ask them of everybody. Unstructured, you could just let someone talk about the issue. My favorite, which I forgot to put on here, is semi-structured. So you have your few questions, you open it up, but then if the community member or whoever you're interviewing brings up something that you didn't even think of, you explore that with them, right? And you go deeper into that. And then if you have a second interview with somebody else, you say, someone else brought up this issue, what do you think? And that's a way that themes that maybe you never thought of can come out of those interviews. And you can learn something new from the population. Focus groups are structured, can be structured or unstructured, and it's a small group setting. And then anecdotes are always unstructured. I already talked about surveys. So focus groups, ideally 6 to 12 people. It can get really rowdy. Ideally a moderator and a note taker. I've heard a lot of local focus groups are done just someone taking notes, and it makes me cringe. Please record things and go back and type it up. Because if you're just taking notes, you're processing the data in that moment, and none of us are that good and that quick, right? Series of different groups should be conducted for validity. We might not be able to do that, and that's okay. And if that's something we can't do, just noting that and just saying it. That's how you make good research. So I can't do this for X reason. And then considering our participants, are they all the same? Are they anonymous? Is this a safe space? And keeping note, if you have a strong personality in the room, it's really going to color your results. Anecdotes are the stories that we get from the community, and we get these all the time, and we take action on these all the time, every day, right? We get a phone call from somebody telling us, like the example, the Raisin Hoopa is closed. People are really upset. Right? So we can choose to follow up with key informant interviews in the community to ask what supports the community wants, or if we know we only have X, Y, and Z resources available, then we just mobilize those resources without doing the interviews. Because maybe we don't need to. Maybe that's all we have to offer, right? Both of those are good strategies and good ways to use that anecdotal data. The key informant interviews, formal conversations with key people who know what's going on in the community. Collecting information, ideally from a wide variety of people who have firsthand knowledge of the community or the issue at hand. And you can do these in person, by phone, email, or Skype. I did my research via Skype with people here in Humboldt County, and it actually worked really well. So if you have somebody down south and you can't get down there, or in the east and you can't get there, and if they have a way to access internet, that can be a great thing to do.
Do you record them too?
I do, yeah. Yeah, most laptops, like if you're Skyping, you can record the audio, and then I would go back and transcribe. You could also do that on the phone. I prefer Skype because then you can see their expression, and you can kind of see when someone wants to say something but isn't, so. And local qualitative data. So PhD students and professors who are conducting research are perhaps not publishing it and are sitting on a lot of stuff. So if the university has a department or a class that focuses on your subject, connecting with those professors and asking, like, hey, do you know any students who have done a project on this? Are you yourself sitting on any data? That's a great resource. Documents of any local organizations. And then the key informants we already talked about. And if you don't have time to do focus groups with 30 people, just do key interviews with a few. And better less data with really good methods than a lot of data with really poor methods. And that's what I got. Does anybody have any questions? I also actually have an activity if we have time, but I don't know if we do.
Can I share a story about how valuable qualitative data is?
Yeah.
I'll try to keep it really short. This was sort of at the very beginning of the oral health inquiry. I was hired to do focus groups in 3 communities to look at both iron deficiency anemia for children and children's oral health issues. And I was paired up with an epidemiologist here at the county. And we went into the whole oral health thing kind of naively because we have had good oral health through our life. You know, we have a dental home, we get our cavities filled and stuff. And so we really thought iron deficiency anemia was going to be the big issue in the communities because there are lots of health effects. So we really kind of over-prepped on that side and under-prepped on oral health. We went into, it was Oric, McKinleyville, and Rio Dell. And I tell you, I have never seen focus groups with such angry parents. They're like, I can use all kinds of such a recording, I can't say it. But anyway, they were like, I really don't care about iron deficiency anemia, but my kid has cavities and there's no place to go. And we're like, wait, what do you mean there's no place to go? There are dentists all over. No, nobody accepts Medi-Cal. You know, it was kind of like, it really tore off our naive, you come in, as you said, you come in with biases and you think that you know the landscape, but it was quite an experience to really hear and see from parents who were angry about wanting good care for their kids but couldn't get it. And it started, we just kind of abandoned iron deficiency anemia and focused on oral health, and that was the genesis of it. So it was pretty cool. So it was, we kind of left with singed eyebrows. But it was an amazing experience, and I'm so thankful for doing qualitative research in communities. It's a must.
I agree, and thank you for sharing that because that really speaks to having to leave our biases behind as much as possible and being open to the fact that our community really does know what they need, right? And it can be hard because we're in the middle of this structure, you know what I mean? Like whether we came from the middle class, we're kind of in a middle class organization with a certain level of income and certain access to resources. And so that does color the way that we think about the world and we see things happening. And yeah, so thank you for sharing that. Does anybody have any questions or comments? Do we have time to do an activity?
Yeah, what do we have left? I think what we should do is go to the next topic and then return to the activity.
Okay.
Does that sound okay?
If we have time, yeah.
Just because I think it would be good to make sure we get everything done here.